So we're going to discuss management, and we're going to begin with a case. This is Winona. Winona is a 7-year-old young girl, who was diagnosed with atopic dermatitis at the age of 9 months. And this has involved primarily her forearms and lower legs. She has been managed to date with moisturizing agents or emollients, which have been administered 1 to 2 times per day. And she's also been treated with low-potency topical corticosteroids for treatment of her lesions. When we questioned Winona, she is really not happy. Her itching has not improved dramatically. And this really affects her when she plays sports, she plays soccer, and she says it's very difficult for her to get to sleep or to get good quality sleep at night. And we look at her on physical exam, she has some of the stigmata of moderate atopic dermatitis. She has redness, and you can see she has excoriations that we see on her trunk. We see this on her arms and legs. Fortunately, no signs of infection.
Well, our goals of therapy then are going to be, first of all, to reduce the number and severity of flares, of course, to reduce the pruritus and thereby improve her quality of life, to try to maintain the normal activities of daily living that she already finds can exacerbate her disease, to maximize her disease-free periods, to prevent infectious complications, and to avoid or minimize the potential risk of side effects from the therapy itself. Now, when we think about how to do this, we can talk about mild disease versus moderate to severe disease, and it becomes an algorithm of treatment that allows us to build on what is basic management and then add other elements. So the basic management of skin care is, of course, the vigorous use of moisturizers, to take a warm bath or shower as long as you do use moisturizers, and to avoid triggers. Now, with acute treatment then, we can add to that generally a low-potency topical corticosteroid for milder disease applied to inflamed skin. And alternatives are some of the non-steroidal agents like topical calcineurin inhibitors or the new crisaborole. And then as we advance to the more moderate to severe disease, we tend to need stronger therapy. We might use a medium potency topical corticosteroid to the inflamed skin to try to quell a flare. We would look for secondary infection and treat it with a systemic antibiotic if present, and then use dilute bleach baths 2 times a week to daily as needed for maintenance treatment to help both reducing infections and also to decrease the inflammation itself. And in those individuals who don't respond to that, then we have to consider, is it because there's not adherence to what we have prescribed, which is very common? Is it because perhaps there's a misdiagnosis, we're missing something that needs to be treated in a different way? Or is it just that it's too severe and we need to think about next steps? For those who have milder to moderate disease we can get under control relatively easy, then we need to figure out maintenance. And maintenance can be very tricky because really the risk of treatment is in continuing chronic use, for example, of stronger topical steroids. So how do we use maintenance corticosteroids? How do we use maintenance non-steroidal agents? And how do we turn that into a regimen that is able to quickly quell the flares but allow safe continuing treatment?